The next section deals with medication and heart disease. One of our pharmacists has been kind enough to talk to us about some of the commonly asked questions that people have when they're faced with the number of medications that are started either after heart bypass surgery or when the heart diagnosis is made. There may be a number of different issues that come up, and Daniel, our pharmacist, will deal with those in the next section.
When you have a patient that is presenting to us, they may be put on a regime of medications to try and prevent further problems. And so there are a number of groups of medications that we'll use, all designed in many cases to prevent more narrowing of the blood vessels, which basically can be caused by two main actions. One is through the formation of blood clots or scabs through those blood vessels, and the other is the build-up of cholesterol that forms over time. So we tend to use medications, of course, that are designed to thin the blood, and these include things like aspirin, and are quite often lifelong medications once they're started. Well, there are a number of things that I think are very important when it comes to medication management. And if I just take you through the process, whenever we're visiting either our GP or a cardiologist, it's important to take maybe a checklist along with you, a set of questions that you have available, or your partner or your significant other that comes with you, hopefully, will be able to put to that doctor in the 5-minute consult. Certainly, if at any time or every time that you visit that GP or cardiologist, it is worthwhile having a list of your current regime with you. All right? Don't depend on the doctor to have that regime up on their records, because things change, and sometimes the communication between health professionals can sort of lag behind in terms of your visit. So something that the cardiologist has potentially changed in your regime may have not yet reached the GP, and vice versa. So it's always worthwhile, as the patient, as the centre of the treatment team, is to have a list of your current regime with you and take that with you. If the doctor is suggesting to you that medications need to change on that list, and they need to change today, then your questions to them should be, what is the medication for? How long do I need to be on it for? Does it replace anything that I'm currently on? Because they can go both ways there. They can say, yes, it replaces this drug, and therefore stop that drug and start this drug. Or they may be adding in that medication to complement what you're already on. Okay, and certainly it's important to get that clear, because occasionally, if you read the information that either comes with that medication or is given to you by the pharmacist, you'll note that one medication may be doing the same thing as another. And you often wonder, should I be on both of these? When in fact you're using two together to minimise the dose of those drugs, and therefore try and avoid some of the side effects that you see with those drugs. The other aspects that I tend to touch on with your doctor would be, how do I take this medication? Right? How often, how many times a day? Right? What side effects should I be watching for is the other question that you'll often ask, and good luck on getting a response to that one in that consult. Once they've given you the script, you take that script with you, and certainly a lot of the answers that you're getting, I would make sure that you write them down, or have a significant other with you who's going to remember that information for you. Once you're out the door and off to the pharmacy to get that prescription filled, before you leave that pharmacy, make sure that the drug is being presented to you, the label's being presented to you, and read the label. Make sure that the label matches what you think you've been told. All right? And if at all there is some discrepancy there, then you're within your rights to ask that pharmacist, please check this dose for me with the doctor. And they'll ring them and clarify that. Surprisingly, pharmacists and doctors make mistakes, believe it or not, and certainly it's more important that we get it clear before you take that medication home with you. What we tend to say is try and take your medications at about the same time each day. Try and fit them in with what you're doing at home, with your daily activities. A lot of us say, please take your medications around a mealtime, for instance, something that you're going to do every day, potentially whether that's breakfast or dinner, and that can vary from person to person depending on your lifestyle and maybe potentially your working habits and so on. But the best idea is to fit it around what you do rather than getting the drugs to sort of control you. Most medications are okay and should be taken with or after food. There are only a very small percentage of medications where the drug's absorption may be affected by food, and there'll usually be an additional label on those drugs on the label that suggests that they should be taken before food. So that's generally how we'll do it. We'll try and simplify the regime as much as possible. So if there are medications that are taken once a day, we'll try and group those together where possible around the mealtime if they're safe to take together. But certainly if there are medications that are taken more than once a day, then it makes reasonable sense to take them at breakfast time and at tea time in many cases, and then grouping medications around those times to make it as simple as possible. Keeping your medications in a central spot in the house is probably a good idea. Keeping them where you're going to go to every day, whether it's near your breakfast crocs or so on. But keeping in mind who has access to that area. Okay, if you have little people that are around and children and so on, obviously we need to be safely handling those medications. And we also need to think about the environment that they're in terms of a lot of these medications are stable in normal conditions, but certainly you get the temperatures above 30 degrees or you get damp conditions, and some of these medications can break down. So it's important that they're in a dry, cool, darkish area, not necessarily your fridge, but certainly not on the windowsill or near your sink would probably be an ideal spot. And getting your medications out at the time of you taking them is probably the best idea, rather than having your tablets out for hours on end on your bench. But having a container potentially that you might want to use, like an egg cup or a saucer that you put your tablets out, you count them out onto, and then you take them at your mealtime, so that you can then look at that container down the track and say, yep, that's empty, I've taken that medication, I can feel quite confident. One thing we need to be aware of, however, is that we do tend to go into a bit of automatic mode. And everyone's guilty of that at times. And you'll so-called wake up during the day and think, gee, did I actually take those medications when I was supposed to? Chances are that you have. And certainly if it's outside a couple of hours of your normal time, our advice to you is to not to worry too much about it and go on as normal at the next dose, rather than accidentally doubling up the dose of the medication that you've potentially already taken. It's much simpler to say, I might have missed it, let's go on as normal the next day. In the majority of the medications, their action will last up to 24 hours or beyond. And certainly for someone that's been stabilised on a medication for many days or weeks or months, the odd dose that's missed is not going to be the end of the world. It's certainly not ideal and we wouldn't want to repeat it, but it certainly shouldn't sort of panic you into any sort of things that get you into even more trouble. The ideal is to try and remember that drug each day, and sometimes we'll need a little bit of extra extra help, and people talk about the idea of a dosette or medication management aids. One of those such things is called a dosette, where they'll actually have a box which has the days of the week along the top, and in fact, so Monday through to Sunday, and has compartments for the times of the days, whether it's morning, lunchtime, tea time or bedtime. And you can simply put your week's worth of medications into that box, and as long as you remember what day of the week it is, you can open it to that particular time of the day, and there are your medications for you for that time. And that certainly works for a lot of people, just for looking for that added reassurance that they've taken their medications. And certainly also is useful to have if you're going away for that weekend down the beach house. Rather than taking the second suitcase of medications, you can take just that container, importantly with an up-to-date list of what's in there. God forbid if you fall ill while you're away, you've got that list with you, and so that you've got that box to use while you're away and beyond. In terms of going away on holidays, which is lucky for you, certainly what we tend to suggest is that work out how long you're going away for and make sure that you have enough medications with you to last that entire time with some spares, okay? Just in case there's a delay of you getting home for one reason or another. It's worthwhile having a copy of your prescriptions with you, with the medications, and also an introductory letter with you from your GP or your cardiologist explaining what your conditions are, and your history, of course. If you're going away for an extended period of time, keep in mind that with the PBS, with the government scheme, generally when you get a prescription filled, you get roughly a month's worth of that medication. There are exceptions where you get a bit more, but generally a month. And if you go straight back to your pharmacy to try and get that script filled again, they'll generally say you can't have that script filled within 20 days of having the first script filled. Now, there is a regulation that allows you to get more than 1 month dispensed at one time. But a regulation can allow you to have all of your repeats filled on that setting, and that's particularly important for someone that's going away for an extended period of time. You can get all your tablets to take with you. Also, the other aspect that needs to be kept in mind is that there are a number of more expensive medications that are provided on what's called an authority prescription. Now, this is quite a different prescription to your normal everyday PBS prescription. This is a prescription where your doctor, be it your GP or your cardiologist or other specialists, need to provide a special code or ring Canberra to get a special code to allow that medication to be prescribed to you, and you must have particular condition that allows you to have that medication, either because the medication is a drug that only should be used for that condition, or it's a very expensive medication which is being subsidised by the government, and therefore they want it being used for specific conditions. And those particular medications can be, in some cases, quite difficult to come by when and if you're travelling. So it's doubly important to make sure you have plenty of quantities of those when you do go away. Government of Australia has certainly arranged the PBS or the government system of reducing the cost of medications to us, the public, and in doing that, they're trying to minimise the cost to the taxpayer. So drugs have a certain patent where The manufacturer in Australia, for instance, can produce that drug, and solely that drug, no other manufacturer can produce that, for up to 10 years in Australia. Once that patent is reached, other manufacturers are able to produce that drug, but a different brand, and those are termed generic medications. Those drugs, for instance, are only able to be offered to you if they contain the same drug at the same strength. All right. However, the additives, the colourings, and so on in that tablet or capsule or product can be different, and therefore the tablet, the capsule, can look different in terms of a colour or a shape, and certainly the packaging will be quite different along with the brand name. So certainly you're within your rights to take that generic drug, but if you do, just make sure that if it hasn't already been, write on that packet the brand that you're used to, so that you're not going to get confused between the two different brands. You know they're the same thing. And while you're at that pharmacy, make sure that any of the questions that you might want repeated in terms of what are the side effects. An excellent question for the pharmacist to sort of filter that information for you, to give you the most important side effects is worthwhile. And if there isn't an information sheet in that packaging, then the pharmacist at that time is able to print out a fairly comprehensive information sheets for you. But a word of warning with those information sheets is read them but have them sort of potentially filtered or talk them through with your pharmacist so that they can sort of work you through what it's for and potentially the side effects of that drug. The other agents that we find that are quite commonly introduced into a regime, particularly where the cholesterol of the particular patient is identified as being a little high or unbalanced, we'll start a cholesterol medication, and there are a number of those in that group, one being the statins, and another group that we see a little less commonly but certainly are available, the fibric acid derivatives. All of those will generally look to reduce the total cholesterol by about 20 to 30%, and more importantly are designed to get more balance in the good and bad cholesterol in the individual. Statins are a medication that we use to reduce cholesterol, and when we talk about cholesterol we refer to both a person's total cholesterol, but more importantly the balance between their good and bad cholesterol. Good being something called HDL or high density lipoproteins, and the bad being LDL. And what we want to see is a better balance between those two, less of the LDL, more of the HDL. And in doing that, we're also lowering their total cholesterol to somewhere below 4 if we can get it there. Now, the statins are a group of drugs that have been used for many years and certainly have a lot of evidence behind them in terms of drugs that can reduce that total cholesterol in numbers of 20 to 30%, but they need to work, or to work effectively, they need to be combined with a healthy lifestyle, which includes diet and exercise. Your body will get its cholesterol from two means. One, we absorb cholesterol from our food when we eat, but also our liver produces cholesterol, and cholesterol is important in our bodies for the structures in our cells. The statins work at the liver to reduce the production of cholesterol, and in doing that reduce the cholesterol in our bloodstream. Like any medication, there is a balance between good and bad effects, or side effects and therapeutic effects. Generally, when you're started on a statin, we will start you on a moderate dose, and that dose will then be adjusted according to your response to the medication and, importantly, where the cholesterol level is seen to go in terms of, hopefully, down. Generally, they will look to review the cholesterol level when they've commenced a statin. Within about a month, they'll do a fasting cholesterol level, which will then determine if all is well. I guess the most important things to mention when you're first on any medication, and including the statins, is if anything is interfering with your lifestyle in the first few weeks of starting a medication, or at any time for that matter, it is important to get it reviewed by a health professional. All right? Always be asking questions. Could this be my medication that's causing a problem? In particular, specifically to the statins, there are two main things that I tend to tell people about with that group of medications. One is that it can irritate the liver, and in doing that, we can see increases in chemicals that are released by the liver. And this may result in the need for the drug or the dose to be either reduced or changed. But that's certainly something that is almost like an allergic reaction, and is certainly something we're looking for, but not necessarily happening with every patient that goes on the statins. The second important thing with statins is that a lot of people that are on it can develop significant muscle pain or weakness, and this can occur over a 12-month period or even beyond that, and is certainly something that if you are having difficulties performing your normal everyday tasks, if you were getting muscle pain from even the simplest things, or just aching, and particularly towards the end of the day, it's worthwhile reporting. It may not be the medication, but they can do a simple blood test to check if the medication in fact is irritating your muscles. And again, it's easily reversed. The medication is stopped. You potentially transferred onto an alternative drug, and hopefully we can continue to keep your cholesterol low. Certainly a drug, this group of drugs is not something that we need people to be afraid of. We do need them to be alert and to be wary of any new medication that they're started on, but certainly they've been used in a wide variety of people, and the benefits that we see with someone being on long-term statins far outweighs some of these risks in terms of reducing risk of heart attack and stroke. With the fibrates, they're used less. We see them being used less commonly. Statins certainly remain first line in the majority of people that have high cholesterol. Fibrates can be specifically used in groups of patients that have problems with high triglycerides, which are also a particular chemical that's in our body related to cholesterol. On occasion, very occasionally, they may be combined with a statin where someone has a complicated system where their cholesterol is high and their triglycerides are also high, but that combination is quite rare. These have similar side effects to the statins, particularly if used in combination with statins. We need to be extremely wary of the development of muscle pain or weakness in that group of patients. With ezetimibe, it is an excellent add-on drug. We use it in combination with statins to again get a little bit more control over that total cholesterol and that balance between the good and the bad cholesterol. It has advantages over the fibrates in that when combined with the statins, There is some evidence potentially that there's less risk of muscle pain and weakness. And also it's an excellent drug when someone, say for instance, we've tried to increase the cholesterol dose, the cholesterol lowering agent dose, the statins, to such a point that it has caused side effects. But we still haven't got control of as good a control of cholesterol as we'd like. So what we often will do is that they'll reduce the dose of the statin, but add in the ezetimibe to get hopefully some better control of that cholesterol. Another aspect that it's used, or another side of therapy that it's used, is where someone can't tolerate the other agents at all in terms of the statins or the fibrates. They may try ezetimibe on its own, so-called monotherapy, as a possibility of reducing the cholesterol. Just with ezetimibe, it works slightly differently, or quite differently, to the other agents, in that it reduces or inhibits your cholesterol absorption from food. That's its main difference in the way that the ezetimibe works. And certainly we've seen it as an alternative to a very old group of drugs which was used in a powdered form to reduce cholesterol absorption. It was not very palatable, and so in a tablet form, which is what ezetimibe is, we get a palatable drug and less absorption from food. But it does not have any effect on the cholesterol that our body produces as such, and therefore it has a bit of a limitation in that side. Quite often the patients will say, look, my GP has suggested that my cholesterol has been fine up until coming into hospital, for instance, or seeing the cardiologist. And certainly without any history, a lot of people will be able to, obviously with a good diet and exercise, their bodies are able to tolerate a cholesterol, maybe a total cholesterol of 5 or 6. But once they've shown some history, whether they have some narrowings in their blood vessels, identified through angiogram, all bets are off. The dose, the cholesterol really needs to be lowered, and that is done generally, again, in combination of diet and exercise, but with a cholesterol lowering agent as well. Along with that, we'll find that a number of people are started on at least 2 other medications. One being what's identified as a blood pressure medication. Now, this is not necessarily saying that you have high blood pressure, but what they're designed to do is open up the blood vessels, and by relaxing or opening the blood vessels, they take the pressure off the heart, and therefore the heart can function a lot more effectively. And the group of drugs that we often refer to are ACE inhibitors, or angiotensin 2 type 1 receptor inhibitors, which is a big mouthful of a drug, but we often look at the ACE inhibitors more commonly first, because they have a lot of evidence behind them in terms of not only protecting your heart, but protecting other organs in your system as well. The angiotensin 2 receptor blockers are certainly used if someone develops a cough from the ACE inhibitors, but we do also find, particularly out in GPs are using quite a lot of it first line to treat things like hypertension or high blood pressure. When we have a patient that comes in with chest pain or what's called acute coronary syndrome, after they've been assessed and potentially, in many cases, they may have also been through an angiogram, and the decision is made that they will have an angioplasty and potentially a stent put in. We will try to see that patient within 24 hours of having that stent put in. When you have a stent put in, of course, as has been explained, that is like a piece of chicken wire. They're putting it into the blood vessel under pressure, and there's a real risk that the blood can clot or scab inside that blood vessel. And in these cases, aspirin as a blood thinner is not enough to keep the blood from clotting or scabbing in that stent. And we'll often use what's called dual therapy, where we'll actually use two agents to thin the blood, which are both what they call antiplatelets. They work on the platelets, which are part of the blood, to stop the blood sticking to the walls of the blood vessels. And these the other agents that are added to aspirin can be things like clopidogrel or prasugrel. As you can tell, those drugs are fairly similar in nature. And there is a new agent called ticagrelol, which is also becoming available. And these agents are used together in combination, as I said, to keep those blood vessels free of blood clot, and are generally used for at least 12 months to reduce their risk of another heart attack or angina. If we run through them as I normally do with a patient as we talk through the groups, certainly the antiplatelet or the blood thinning medications like aspirin and clopidogrel for that matter, and the others that I've mentioned, all, as I mentioned, thin the blood. And by thinning the blood, it means that they're stopping the blood from clotting or scabbing where we don't want them to in the blood vessels. But what also happens, of course, is that they cause the patient to bruise and bleed a lot more easily. And certainly we have a lot of people that do complain about the bruising on particularly the backs of their hands and on the thinner skin on their shins and so on. They wonder where the bruising is coming from often. With aspirin, particularly, it also has a tendency to irritate the gut. And that is why whenever someone is put on aspirin, we recommend that it's taken with or after food to avoid irritation to the gut where possible, and certainly reporting any issues with reflux or indigestion out of the ordinary to their doctor, whether it's their GP or their cardiologist with those drugs. If they notice anything out of the usual in terms of signs of bleeding, that means nosebleeds or bleeding from either end, then we would also like them to seek some attention, because it may be that their regime needs adjustment. And just on that, certainly with the dual therapy of the antiplatelets, where we've got them on two agents when they've had a stent put in their blood vessel, we must be sure that if you're started on those medications, you must remain on them. If there is a doctor, a dentist, a surgeon, anyone other than your cardiologist is asking you to stop those medications for one reason or another, they must be referred to your cardiologist before that happens, so that the risks and benefits of those agents being stopped is weighed up. In terms of warfarin is a drug that has a long history. It's a drug that has a lot of good and bad stories about it, and it is used in a wide variety of people. Anything from 15-year-olds up to 90-year-olds will be on warfarin for one reason or another during their life. We have some people that are on it only for 2 to 3 months. We have other people that are on it for life. It's a blood thinner, a specialised blood thinner, which works on the clotting process. So it's often known as an anticoagulant because it works on the clotting process in our body, which is ever so vital to protect us when we damage ourselves, when we cut ourselves, but also is a process that can be dangerous when clots are happening in your bloodstream. And that particularly occurs when you have something like a deep vein thrombosis, where you have a clot in either the vessels in your legs or your arms, or if you have a pulmonary embolus, which is where a blood clot has formed in the bloodstream in your lungs, both of which are extremely dangerous situations that need to be treated quite strongly. With respect to the heart, we tend to use it where someone has an irregular rhythm to their heart, something called atrial fibrillation, where their heart is pumping potentially very quickly, but certainly very irregularly, and it puts a very high risk of the blood clotting or scabbing, and then those blood clots being shot to places like the brain, causing a stroke. So to prevent that, we not only use medications to control the rhythm of the heart, but we need to use warfarin to keep the blood thin. And in that setting, people may only be on the warfarin for 1 or 2 months until they're confident that the heart has gone back into the normal rhythm. Or if it is a consistent problem that people are living with, then the warfarin may need to be more long-term. The other cardiac indication that we see it being used in is where someone has had a mechanical valve put into their heart. And when you have a mechanical valve in your heart, it's almost like the normal heart valve, but there is the risk that the blood can clot in and around that valve and cause particular problems in terms of those clots forming, and therefore stroke is a reality with it. Anybody that started on warfarin should gather as much information as they can about warfarin. Right? Whether they're started at their GPs, whether they're started at hospital, okay, or in hospital. And certainly the provision of sort of products like this. This is a warfarin book or a blue book, which is provided by the manufacturer, and pharmacies can get hold of this for you. There are also some printed materials that can be printed off from a website. The website is www.anticoagulation.com.au, and that is an excellent resource which I would recommend everyone going to. It is a drug that comes in a number of brands, both made by the same manufacturer. So this particularly is important because if anyone is shifting or starting warfarin, we like them to stick to the same brand if they can, simply because the colour coding is quite different from one brand to the other. Right? And it can cause quite a lot of confusion if we're swapping. All pharmacies should keep both brands, and as I said, it's best if you can let them know and your GP know what brand you're on. Warfarin itself is taken generally once a day. Most people take it in the evening around tea time. It doesn't matter whether it's before or after meals, but just keeping it consistent would be the most important thing. And what I mean by consistent is within a couple of hours of the normal time each day would be ideal. Taking it with your other medications to remind yourself to take it works exceedingly well with most people. The reason that we have it in the evening time is it's a drug that needs to be monitored. Unlike aspirin, which we also use for blood thinning, aspirin doesn't need to be monitored. We don't need to test the blood. It's one dose fits all. With the warfarin, the dose needs to be adjusted to suit your particular needs and your particular makeup. And everyone is different in terms of what dose they may require for warfarin. So it's taken once a day. It's best if it's taken, as I said, at the same time each day, every day, and that the blood testing, which is something called an INR, which I'm often asked, what does that mean? And what that is basically a measure of how quickly the blood forms a clot or a scab. Right? The slower that process is, the longer it takes for the blood to clot, the higher the INR is. And what we look for is a range between about 2 and 3. When you're on warfarin, we want you to have an INR between that range. The higher the number, the so-called thinner the blood is. Blood is usually tested at least, well, it is tested once a day while you're in hospital or while you're initially on it, until such a time that the warfarin has reached that therapeutic range. And beyond that time, either your cardiologist or your GP will then tell you how often that blood needs to be taken. Usually about once a week for about the first month, and then beyond there it can start to spread out even further. For those of us that are on warfarin for the rest of our lives, and that's particularly people that have a mechanical valve, that blood testing may only need to be done every 4 to 6 weeks. So it gets a lot easier, but it's that early stage that can be a real drama. Basically, because it thins the blood, it makes you bleed. All right? There is real potential that it will cause you to bruise, no question of that. And we have patients always coming to us about they've just knocked themselves, or they don't even remember knocking themselves, and they have bruising. It will cause bleeding. So, for instance, if you have a tendency to bleeding in terms of nosebleeds or bleeding from either end in terms of blood in your urine or blood in your stool, then it's going to increase the tendency for that. And that certainly produces a lot of anxiety in the community for sure. Now, the bottom line is that we need to get the dose individualised at such a level that it's therapeutic, but that it's not causing this extra bleeding. And that's the art or the balancing act that your doctors will work through over the initial time that you start this medication. The other aspect with it is that the warfarin's effect on your system is a fine balance. It can be affected by a lot of things that are going on, both in your health, particularly when someone becomes unwell through sickness, through even a simple cough or cold, can upset that balance. Other medications can be a real issue when it comes to warfarin. There are a lot of medications which can interfere with warfarin and result in the need for the dose of the warfarin to be adjusted. Anything that you're already on in terms of medications before you start warfarin will be adjusted for when you're on the warfarin and getting the blood tested. But anything new that is started, the first question you need to ask is it safe to take with warfarin, or does there need to be any increased monitoring when I start this medication? All right? And the golden rule I tell everybody is don't start anything without the permission of your prescribing doctors. And that involves prescription medications, because all of us are seeing different doctors at any one time. But it also relates to things that we're buying over the counter at your pharmacy, at your supermarket, health food products, and what they call complementary medicines or vitamins. All of those need to be clarified as safe to take with warfarin before they are started. A number of people will talk about something called vitamin K, which is found in green leafy vegetables. Vitamin K works opposite to warfarin. So it's actually used as an antidote if someone takes too much warfarin, or we need to reverse the effect of the warfarin for people coming in to have surgery. So green leafy vegetables like spinach, lettuce, cabbage, broccoli, Brussels sprouts even. A lot of people think, great, I don't have to eat any of those, I don't like them anyway. But in fact, it is important just to keep a nice, balanced, regular diet. Those green leafy vegetables can be part of your normal diet, But just eat them as a small serve, a mixed veg, a mixed salad. Don't go overboard. Don't cut them completely out of your diet, but don't just eat green leafy vegetables. Vegetarians can still be on warfarin. It just means keeping that process in mind. The other question, or one of the last questions I often get asked is, with warfarin, is that what can I drink in terms of alcoholic drinks while I'm on warfarin? Like everything, it's best to continue to drink in moderation. The most important thing to avoid is what they call binge drinking, where we save up all our drinking for one day, because that will affect how the warfarin is handled by the liver, and therefore will upset that fine balance I've talked about in terms of that thinning of the blood. If someone is to have 1 or 2 standard drinks each day with a meal, then that is perfectly safe to continue with that practice. But as I said, if someone is tending towards 4, 5 or 6 standard drinks at any one sitting, then that's going to potentially cause their INR to be quite variable, and therefore there'll be a need for them to have their warfarin adjusted. In terms of side effects, be aware of the potential for bleeding. Right? It will make you bruise and bleed extremely well. So if we find that we're getting anything unusual, nosebleeds that are hard to stop, bleeding from either end, the doctor should be alerted to that, and therefore the warfarin dose may need adjusting, or an alternative sort if need be. Anyone that is on a blood thinner, whether it's warfarin, whether it's aspirin, or whether it's the other antiplatelets like clopidogrel, prasugrel, it needs to be remembered that these agents work over a long period of time while they're in your system. And therefore, if someone needs surgery while they're on a blood thinner, whether it's a simple dental procedure or whether it's a full-on surgical procedure, that specialist or surgeon or dentist who is performing that procedure must know that you're on that blood thinner, and guidance must be given on when and if the blood thinner needs to be stopped before surgery. As a golden rule with most blood thinners, particularly for significant surgery, they look to stop those medications 5 to 7 days before the surgery is performed. And certainly, depending on the indication for your blood thinner, there may be a need for admission into hospital or an alternative blood thinner sort of used in that setting before surgery. The most important thing beyond surgery, of course, is to know when the blood thinner can be restarted. Because the problem we have in many cases is people have their surgery and the blood thinner is then not recommenced until several weeks down the track, and that can put you at significant risk. So it's important not only to have guidance on when to stop it, but also when do I restart it. And having that information before your surgery, I think, is a lot more effective than, say, asking in the recovery room, when do I start my blood thinners again, when you're affected by the anaesthetic. With the beta blockers, they're one of the other groups of drugs that people are commonly started on when, say, for instance, they've had a heart attack or if they have angina. The beta blockers are a group of drugs which are quite often recognised by a lol on the end of the name of the drug. And when I talk about names of the drugs, it needs to be recognised that there is always a brand name and a generic name when it comes to these drugs. And the other confusing matter, of course, is that there's many different brands now of the same drug. So it's vital that we are clear on that side of things. With respect to the beta blockers, they are designed to slow the heart down. And in slowing the heart down, they allow the heart to rest. And as the heart rests, it will fill. And as the heart fills, it stretches the muscle. And if we stretch muscle, it's like pulling a rubber band. The further we pull it, the stronger it's going to snap back. And therefore the action of the beta blockers is to rest that heart, because when a heart is starved of oxygen, like it is in the case of angina and heart attack, it can go into shock, and it may not function as well as we'd like. By putting you on a beta blocker, and certainly any patient that it is recognised that they have some damage or some a heart muscle not functioning well, should be on a beta blocker to slow their heart down and try to get the best function out of that heart muscle as possible. All right. The problem with beta blockers, of course, is that they can drop the blood pressure. So they can make some people feel quite dizzy when they first start them, and that goes for all of the medications that lower blood pressure. So the ACE inhibitors and the angiotensin II receptor blockers are certainly also prone to that, and particularly when someone is started on 1, 2 or 3 different agents that are potentially lowering the blood pressure. People need to be very aware in that first week that they've started that medication, that they're potentially going to feel quite giddy when they get up out of bed or up out of chairs, and certainly any time the dose of that medication is increased, and in fact there is quite a lot of potential for that to occur over the several months after the first episode. That first week or so of that change, they need to be aware of that dizziness raising its head. The other issue with beta blockers is that it can make some people feel quite breathless when they first start them. And in fact, we use the beta blockers to treat what's called heart failure, where the heart is failing to pump the blood around the body. And in doing that, you're actually getting a build-up of fluid. It's not getting to the kidneys where it's flushed out. You end up with this excess fluid, both on some people on their feet and ankles, but more commonly on and in and around the lungs and heart, and that can make you feel quite breathless, particularly when you lie flat or if you do a little bit more exercise or daily activities than usual. The patient or person may feel quite breathless, and then you give them a medication that potentially will make them feel even more breathless. Quite often the question is, well, why am I taking this medication that's making me feel worse? The answer to that is, if you're persistent with that drug, you'll actually find over that first week or so that things will settle down and that breathlessness will improve, and there'll be subtle improvements in your ability to do those daily activities and to get that exercise going again. The only other aspect with respect to the diuretics or the fluid tablets, these are things like furosemide is probably the most commonly used medication in terms of a fluid tablet or diuretic used in heart failure. And in getting rid of fluid and salt out of our system through the action of that drug, it also depletes our body of a product called potassium. And when potassium gets low in our system, it tends to make our heart more sensitive. It makes it more jumpy, and that can be quite dangerous. So your cardiologist or your GP may prescribe for you, if you're to remain on the diuretic for an extended period of time, which is quite common. They may prescribe a potassium supplement, a Slow K or Dura-K, and that may be 1 or 2 or more tablets that you take in combination with that diuretic to maintain your potassium levels. What also may be an alternative to that, or used alongside it, is another fluid tablet called spironolactone, which is a potassium sparing diuretic. It holds on to potassium and it certainly has proven worth in combination with furosemide, not only because of its diuretic effect, but also it has been proven to improve mortality and morbidity with heart failure and heart attack. In terms of diuretics or fluid tablets may be used in combination with these other agents that I've mentioned, with an ACE inhibitor or an angiotensin II receptor blocker, okay, which are designed to take the pressure off the heart, or a beta blocker designed to slow that heart down and make that heart work more efficiently. When someone has heart failure, that means that their heart is not able, or not at the time, is not pumping the blood as effectively as possible. As I mentioned before, it's not pumped to the kidneys where we flush out our extra fluid. So that can result in what's called edema, or a build-up of fluid in and around the feet and ankles and on the lungs and around the heart. And that can be shown by a patient becoming quite short of breath through exercise or by lying flat. Okay, and the first sign may be that you're unable to sleep at night time without some pillows. And in that setting, the diuretic or the fluid tablet is certainly used because it helps your kidneys get rid of that extra fluid. And by getting rid of that extra fluid, it takes the pressure off the heart, and in combination with those other agents, allows that heart to work more efficiently. Because they work on the kidneys and are certainly designed to get rid of that extra fluid, particularly early on, within half an hour to an hour of taking that medication, and for some hours after that, maybe 4 to 6 hours, you will find that you'll certainly need to be close to the amenities block for that time, because you're getting rid of that extra urine. And that can pose a bit of a problem when it comes to your movements in terms of activities during the day. Sometimes you have to timetable things like shopping trips or what have you. And it may mean that on occasions the dose of that, you may need to think about the dosing of that diuretic, whether it's you take it as early as you can in the day so it's not interfering so much in your daily activities, or if there's the odd day that you can't get out of doing something on that particular morning, then you may choose to sort of delay the dosing of that diuretic until as early as possible in the day when you return home. That's generally what we recommend. When someone is on a diuretic, it needs to be kept in mind that your body gets used to having that diuretic around, that fluid tablet, and therefore you may find that the symptoms that first put you on that diuretic, the shortness of breath that I mentioned, the swelling, the increase in your body weight over time, say a kilo or two each day, is an indicator that the body has got used to it, and therefore the dose may need to be increased by your doctor. In terms of when you have an irregular rhythm to your heart, I've talked about something called atrial fibrillation, and the idea of thinning the blood with warfarin to prevent stroke. But the other aspect of the treatment of atrial fibrillation and other arrhythmias or irregular rhythms to the heart is the use of a group of drugs known as the antiarrhythmics. These are things such as digoxin, sotalol and amiodarone, as well as the group, the beta blockers, which are used to a lesser degree in some cases where we have a rapid heartbeat. These drugs are designed to slow the heart down and to try to bring the heart back into its normal rhythm. Okay. When someone has atrial fibrillation or an irregularity in their rhythm, the electrics of their heart are almost misfiring. They're having these extra sparks, so to speak, on the surface of the heart, and potentially the top of the heart is not coordinated with the bottom of the heart, and therefore that's a dangerous setting to be in. These medications are designed to work on the electrics of the heart to try and get that heart back into its normal rhythm. They may be medications that are used for a short period of time, maybe 4 to 6 weeks, from the time of the diagnosis of that irregular rhythm. And in that time, the heart may well, in its own accord, return to the normal rhythm or the sinus rhythm with the aid of those medications. If in fact those medications aren't successful, then there are other procedures that may be offered. But in some cases, if the heart remains in that irregular rhythm, these medications may be lifelong. They are certainly, as a group of drugs that have a number of side effects related to them, and particularly things like digoxin and amiodarone can make some people feel quite nauseated or give them quite a bit of reflux when they're first started, particularly when they're given in larger doses, so are best taken with or after food to try and avoid that problem. Sotalol, on the other hand, is one of those drugs that is the exception to the rule in terms of taking with or after food. It in fact is best taken on an empty tummy. It's best taken half an hour before food or a couple of hours after. And quite often it's a drug that you're taking twice a day. And in that case, what we tend to say to most people is take your Sotalol first thing in the morning and last thing at night. So it's away from your meals. The additional label on that packet of Sotalol will also say take away from milk and calcium products. And generally what we say is at least half an hour to an hour before you have some milk. So we don't want you avoiding milk. You can still drink milk in your coffee and your tea and on your cereal. But if you can, try and take the Sotalol away from your coffee or your tea. Don't wash it down with your cereal or your coffee or your tea. That said, if you're halfway through your meal and you think I didn't take that Sotalol and you're definitely sure, then it's not the end of the world. Certainly you can on the occasion take it at that mealtime without it causing too much drama. And last but not least, the amiodarone has a list of side effects as long as your arm, and certainly you should receive information if you're started on amiodarone on those side effects and how that drug works, and certainly see your pharmacist or cardiologist if you haven't received information on that particular drug.